Hello from the Mayo Clinic in Rochester, Minnesota. I'm Manpreet Mundi, and welcome to our Home Enteral Nutrition Update for 2020. I wanted to start this way to show you what our lives have looked like for the last few months. This is essentially how we've been having all of our meetings, and everyone is still smiling and healthy. So with that, I wanted to have some of the other team members also introduce themselves so you get to know them better. Margaret?
Hello, this is Margaret. Enjoy the conference.
Hi, I'm Sarah. I'm one of the tube nurses. Hope you're having a great year.
Hi, my name's Lisa Miller. I'm one of the dietitians. I hope everybody's staying safe.
Hi, I'm Danelle Olson. I am also one of the dietitians, and I hope you're staying well during this time.
Hi, it's Lisa Epp. I missed seeing you guys in person this year, but I'll look forward to talking with you later today live on our Zoom meeting.
Hi, I'm Jill. I'm another one of the nurses. I hope you're all doing well.
Hi, I'm Martha. I'm one of our nurse practitioners. Hope everyone stays well.
Okay, thank you so much, everyone. So with that, Lisa and I will take over and start our presentation. And here are pertinent disclosures. And really, when Oley asked us to speak to you today about home enteral nutrition, we wanted to look back at the last year and what have been some of the key milestones, if we could use that term, or what have been the more pertinent issues that we have been working on. So Lisa and I discussed these and felt really three key areas, including our transition to ENFit as an organization, the coronavirus, obviously, as well as some of the work we've been doing in terms of enteral formula would be important to share with you. So with that, I'll start with the first topic. And again, these slides, if you've been to a previous Oley conference, should not be new. So I will go through them quickly and hope during the question and answer session, as well as sessions later today, which Lisa will be hosting through Zoom, should be able to address any questions you may have. But in terms of the ENFit transition, the first question always comes up is why the new connector? And again, this really came about due to recurrent tube misconnections. And these were quite variable, but a perfect example from our own institution was where a nurse flushed the balloon port of the enteral feeding tube, causing the balloon to rupture and having the tube fall out. Other misconnections reported in literature had worse outcomes. So, these misconnections have been reported as early as the 70s, where in this patient, milk was given accidentally into an IV, as opposed to in the stomach. Fortunately, the patient survived, but had significant complications. Since then, and this continues, unfortunately, but over 100 cases of misconnection have been identified, and you can see that many of them have had quite poor outcomes. So with this in mind, really Joint Commission and a lot of other safety organizations started to raise the alarm that something needed to be done to prevent these misconnections. So with this in mind, standards were developed for pretty much all patient devices, such as Foley catheters, feeding tubes, IVs, and these standards were developed to make sure that these devices could not interconnect, that we could only connect enteral supplies to an enteral device and not to something else. And so we just happened to be one of the first to undergo this transition, but other devices will also be going through this transitions soon. In terms of Enteral, once this transition was developed, the main manufacturers, developed the Global Enteral Device Supplier Association, or GEDSA, to get together and how their tubes would transition and how we would implement this then across the industry. Again, focused on decreasing these misconnections. And early on, as the prototypes were being developed, some of the issues with this transition started to become identified that perhaps weren't addressed as well. One of the main ones was medications. And again, this transition was occurring, with going from a male to a female end, resulting in possibility of dosing changes. And this would especially be pertinent for our pediatric population, because again, they tend to have smaller doses, and so you have a 5% or 10% difference. That can be a big deal. So those issues were identified and required some redesign of the syringes and dosing syringes, etc., to make sure that they prevented that in the future. So that was able to be addressed. Other issues were also identified, and I do want to say that this is quite healthy process. We want everything that we do in medicine, especially, to go through rigorous scrutiny and make sure that it can meet the needs of the individuals it's trying to serve. So other issues that we identified, and I'll share some of that data, included flow rate, blenderized tube feeding, as well as venting. And with flow rate, you can see we did a lot of this work in sort of our office settings, testing how long it would take to provide certain formula through gravity feeds, typically how they may be done for someone who's a home enteral nutrition patient. And when we tested some of those early prototypes, we saw that the flow rate was slower through the newer ENFit prototypes compared to the old legacy tubes. So this was raised, and I give kudos to the Oley really for bringing together industry, the consumers, FDA, to come together and say, hey, we needed more testing for this. And we were able to then partner with the FDA and design some trials that would try and address this issue. Again, for us at Mayo Clinic, it was very important that this remained self-funded. So essentially a lot of the work that was done, we did it on sort of a volunteer basis, because we didn't want it to appear that there was a conflict of interest. The tubes were donated by the industry, and we were also able to get formula donated to us to do this testing. But it was quite rigorous. I mean, we had to do a lot of tests, and a lot of formulas had to be tested for each tube. So it ended up being quite a lot of work. But you can see that being done here, and we gathered volunteers. So Jacob right here was an undergraduate student learning about science, and we felt this was a perfect project for him. You could see everyone is still smiling, or we're forcing him to smile. But regardless, it was very fruitful for us to do this work. And again, this data, has now been published, but I'll just share with you some of the key highlights of those results. With all of the 14 French tubes, you can see how many we did. So, here are all the 5 legacy tubes, 3 ENFit tubes. What we found is that one of the 14 French ENFit tubes tended to have much slower flow rate compared to the others. Overall, the rest of the ENFit tubes were quite similar to the legacy, but this one tube kind of brought down the averages, and so that's what you're seeing there. This tube no longer is in the market, so you can see kind of the testing did what it was supposed to. In terms of the 18 French, really no difference. You can see that there. 20 French, also no difference. With the 24 French, and this is what we were suspecting, would be that the flow rate would be slower. for the ENFit tubes compared to the legacy tubes. Our next issue was blenderized tube feeding. And this, again, came to us as quite a bit of surprise. Really, and I'll call this discussion. You can't see me right now, but I'm putting that in quote. Discussion between, Ryan Hurt and Lisa Epp, I think was the start of this for us, where Lisa very in good words, educated us that patients are doing a lot of things with their tubes that they're not discussing with their physicians. And amongst other things, one of those is blenderized tube feeding. I think Ryan and I were quite skeptical that people were actually doing this, but we started with this survey. We surveyed some of our patients and found, whoa, more than half of them were using BTF in some capacity in the past. And so, again, kind of being skeptical, saying, well, that's perhaps our own patients. What about outside of Mayo? We partnered with Oley, we partnered with Feeding Tube Awareness Group, other groups, that focus on enteral nutrition, had them take a survey, and again, we're quite surprised at the findings. Almost 90% of patients were using blenderized tube feeding for an average of 71% when it came to the pediatric population. Close to 65% use BTF for an average of 56% of their daily enteral needs in the adult population. So clearly, consumers out there of enteral nutrition were using blenderized tube feeding. So it's very important for us to make sure that we're able to meet their nutritional needs and continue to do so with the new tubes. And, so we again focused on designing a trial that would allow us to be able to gather data regarding that. And so we analyzed the number of formulas that we would look at. We met with groups within Mayo that had equipment that could help us measure the force it took to compress this syringe, kind of mimicking what it would take for someone providing syringe feeding as they would with blenderized tube feeding. We then also used one of our own recipes. And the beauty of using our own recipes is that it really allowed us to also study other variables, such as the blenders that are used. So we got a wide range of blenders, ranging in price. We also then looked at blending time. Could you just blend longer? And would that make a difference in terms of the force required to use ENFit? Again, a lot of testing and all done through volunteer time. So I think this was a major achievement for us. But here's all of the data that you can see there. And when we started to test this, we tested the different formulas. You can see that really for some of these formulas, the ENFit tubes actually had lower force that was required compared to the legacy tubes. Nourish, really no major difference there. Real food blends, also no major difference. When we looked at the 14 French, this was a limit of this study and really a limit of our equipment in that, certain forces were the maximum the equipment could capture. So if it went beyond that, the machine would give us an error. So with that in mind, we had to throw out that data. The FDA is also about to publish the results of their data, so we're eagerly awaiting those results to see if they find any major differences from what we found. But you can kind of see all of those results there, and I'll go through these quickly because this data has already been presented previously. But I really want to get to some of the aggregate data that we looked at. And so this is where we then combined all of the legacy tubes and combined all of the ENFit tubes, and then compared those two. And you can see not much of a difference. When we looked at the 20 French, in terms of longevity, that's where we saw the ENFit tubes actually needed less force. When we looked at the 14 French, there the ENFit tubes required more force. But to me, really, the benefit of this study was that we had so much data and can do other sort of analyses. And so we then, met with statistician and started to look at, well, what if we had all of the variables in there? Would legacy versus ENFit still make a difference when you're comparing it to the recipe that's used or the tube size? And this is exactly what we found. We found that when you have all those other variables put in, the legacy versus ENFit falls out. The recipe that you're using and the tube size make more of a difference in terms of the force than does legacy versus ENFit. With the Mayo recipe, we had all the different blenders, we had the different times of blending, so we added all those extra variables, and when we did that, again, same results. Really, the legacy versus ENFit fell out, whereas the size of your tube, the blender that you use, the time of blending all made a major difference in that. So I think sitting back, looking at these results, looking at the misconnections that continued to happen, we then decided to move ahead with this transition. So I'll turn it over to Lisa to share with us, how we went about making this transition happen and what's been the outcome so far.
All right, thank you so much. So as you can see from our timeline here, this has been a very long process. We were maybe a little overzealous and got ready to go in 2014. And as you can see, we finally completed our transition in June of 2019. So I just want to talk to you a little bit about kind of what steps we made to make that smooth transition to where we are today, a year later, with really no hiccups related to ENFit at all. So the first thing that we did way back in 2014, we actually formed a multidisciplinary team that had nurses, dietitians, education specialists, supply chain management, and physicians who were working in the realm of feeding tube placement and working with patients who were on tube feeding. That way it allowed us to kind of get all of the different opinions of what might be hiccups that we would have with ENFit. Once we developed that team, we decided, well, our first step is really, we need to talk about where are we right now, current state. What tubes do we use? What formulas do we use, both in the hospital and at home? And do we have the ability to get the amount of supplies we need? Because as you can imagine, Mayo Clinic goes through a lot of supplies. So we needed to make sure that we could find companies that could provide us what we needed. And that was probably the most daunting part of this transition, was evaluating the supplies that we needed and really getting those supplies in here. Once we were able to identify which tubes we could use and which supplies that we could get, we did develop kind of a formulary, so to speak, for feeding tubes, which we had never had. And this was really an opportunity to kind of simplify a lot of the supplies that we kept, but also prevent people from getting tubes that they weren't familiar with or maybe didn't know how to use. After we kind of decided, okay, we have all the supplies that we need, we have the tubes in, then we decided, okay, we have a lot of people that we need to educate, both here in the clinic, in the hospital, and our patients at home. And so we developed a number of kind of internal education sessions that were all hands-on with all of the supplies and the tubes in a room so people could come in and ask questions and kind of learn from them. We also developed some YouTube videos, both for our healthcare providers and for consumers at home, that are still available on YouTube to the public, which are a great overview. If you get home and say, I've never had an ENFit tube before, I went in for a tube change and now I have an ENFit tube, there's some great Mayo Clinic YouTube videos to help you figure out what are the things that you need to change and what supplies might be different. Once we were able to kind of complete that education, which did take a couple of months just because we have a lot of employees, we were able to get to June 25th and say, today is the day we are getting rid of all of our old supplies, which we'll refer to as legacy supplies, and replace them all with ENFit. We decided to do that is because we didn't really want to have confusion over having legacy people who are having legacy supplies and some people having ENFit supplies. So we decided just to pull all the old stuff and replace it with ENFit. It's gone amazingly well. In the first month, we did have kind of a follow-up meeting to talk about a few little hiccups, mostly related to medication administration. And once we realized there were a few small adapters that we needed to carry to help for ease of medication administration, as well as getting some pill crushers that really finely crushed medications, we really haven't had any problems since. And actually, we stopped meeting as a group in about August of 2019 because at that meeting, no one had any patients with issues or any providers that had issues. So we decided that after August of 2019, we didn't need to meet anymore. As we continue to talk to our patients who are at home, who are on long-term tube feeding, we have had mostly positive responses from almost everyone. Even our patients who use tubes for venting are not having problems with being able to vent whatever contents they need to. And people are really happy with kind of that twisting system that prevents things from coming disconnected. So really overall, very, very positive response. And it seems like longer than a year ago now because honestly, I kind of forgot about the old way things are going so smoothly now. So that was kind of how we transitioned. So I'm going to turn it back over to Dr. Mundi to talk about COVID-19.
Thanks, Lisa. It's pretty amazing to see all of that work drilled down to just one slide. However, I'm really glad to see how the transition has gone well and is being tolerated by our patients. So shifting right over to our next topic, which is really the coronavirus. And at this point, pretty much everyone on this planet has heard of the coronavirus. Many of us want it gone as soon as possible, but we wanted to discuss how it relates to our patients and what are the steps we're taking to continue to provide care under this pandemic. And really, when we're talking about coronavirus, you see a number of names being used out there, including COVID-19. And COVID-19, or coronavirus disease 2019, is the disease that's caused by the novel coronavirus, SARS-CoV-2. And this was the virus that was detected late last year, and then COVID-19 started to be detected pretty much all over the world since then. So this is data that Johns Hopkins University is keeping, that's readily available by going to this website, showing that worldwide, as of end of July, we have almost 15 million cases, and the numbers continue to increase every day. The U.S., we initially had breakouts in terms of COVID-19 in New York, a few states like Washington, but then we were able to start decreasing those numbers with some pretty intense social distancing. However, as we reopened and relaxed some of those, we started to see that the numbers increased once again. And now, within our our warmer states, so California, Arizona, Texas, Florida, some of these states in the South, you can start to see that the numbers are increasing quite a bit. And with that, most of us need to be aware of some things that we want to cover in the next few slides. One of those are the symptoms. And obviously, this is all over the news, so I'll go through this quickly, but these are some of the key symptoms: fever, chills, cough, shortness of breath, muscle aches, loss of taste or smell. But what's also important to note is that, we've seen a number of individuals present with gastrointestinal symptoms as well, such as nausea, vomiting, or diarrhea. So nutritionally, some could present in this way, and it's important to note that. But main reason continues to be the respiratory issues. When someone is detected to be positive, we really follow them and make sure they're able to breathe and not having issues from that standpoint. If they are, then they're admitted to the hospital, hoping to avoid getting to the level of the ICU. Again, the biggest question we get asked is, who are those at higher risk for developing some of these complications that require hospitalization, intubation, etc. And I think the CDC does a great job of outlining this, so I would encourage you to go to their website, look at what are ways they're recommending for us to avoid getting the virus, and then who are those high-risk groups. In terms of nutritional standpoint, those on parenteral nutrition or enteral nutrition, as far as I can tell, have not particularly been identified as being higher risk than the general population. Now, that really depends on what are the predisposing factors that have led to the development or the need for enteral or parenteral nutrition. So this is where it's very important to work with your local team, your providers, to do a risk assessment as much as possible. But I'll go into, in general, I think, however, we should not count ourselves as low risk versus high risk. I think there are a level of social distancing that we all should be doing. So keep that in mind. Again, number of our main societies have provided some recommendation in addition to the CDC in terms of social distancing, and I think we shouldn't focus as much on high risk or low risk, but really implementing those social distancing techniques across the board. So this is guidelines from our Aspen as well as our Critical Care Society that have focused on coronavirus and the hospitalized and critically ill patients. What are some of the key components? And one of the biggest is limiting exposure. Limiting exposure for the providers, limiting exposure for other patients that are in the hospital, and those family members of the providers as well. So some of the key concepts here that are being used include cluster care, right? All attempts should be made to bundle care in order to limit exposure. So if someone is being admitted to rule out or is already positive for coronavirus, then what really happens is we should limit the amount of times we enter that room in order to limit exposure, but also to make sure that we have sufficient personal protective equipment, gloves, masks, those kind of things. Other techniques, hand hygiene. Probably one of the most important there is. Making sure that we wash our hands thoroughly, back of our hands and between our fingers. Want to make sure we do that on a regular basis. On top of this, social distancing in the hospital setting as well as outside of the hospital setting. And here I've just shown you a picture of what we have hanging in each of our elevators, just to remind us, and we're even limiting the number of individuals that can be in an elevator depending on the size of that elevator. everyone is wearing a mask. Our city, even a week or so ago, shifted to everyone indoors, requiring masks. The state of Minnesota has also done the same thing. And I think that's a very positive move to try and limit this, because that is one of the best ways to limit the spread, but also to limit the degree, the severity of the disease if you do happen to have it. Other things in terms of nutrition, the key here, keeping in mind, is that early nutrition is very important. So we want to start that as soon as possible, and I've kind of listed that here. Enteral nutrition, using the gut if it's functioning, is always our best option. However, there is a caveat here in that we want to reduce exposure, reduce the number of procedures that are done. And so if someone is not tolerating enteral nutrition, we don't want to have multiple procedures done to place a nasal jejunal or these other interventions, but instead want to move ahead with parenteral nutrition, keeping in mind the risks and the benefits of all of those. In terms of calories, again, kind of starting slowly and working our way up to that. When it comes to our home population, number of changes. Again, the focus is limiting exposure. And we do this through a number of techniques. First is to make sure that you are self-sufficient. You have enough training to provide enteral and parenteral nutrition safely. For some, this is just not possible, but we want the vast majority of our patients who can to get to this stage, so that you don't require home health nurse or other individuals to be coming in and helping you. The second biggest component is telehealth. And this has been a drastic change in healthcare, I think, across the country. Those previous things that limited us from engaging in telehealth, such as licensing per state, have been relaxed under coronavirus. And this has really allowed us to care for our patients within their home and limit their exposure from having to travel to the clinic. And we have been doing this quite a bit. In fact, when I'm on clinic, perhaps half of the patients are engaging in telehealth, especially for their follow-up visits, etc. And I'm really, really hopeful that this will continue, even into next year and beyond, because it's so convenient for patients. It's also convenient for us. Our no-show rates are down, and we can make quite a bit of a difference in that way. Same sort of thing, clustering care, advising all of our patients to engage in social distancing, hand hygiene has been discussed, and then masking. I don't think we should make this a political issue. Everyone, when they're indoors, exposed to others, should be wearing a mask. One of the other key factors of this is also not to delay medical care. And I will show you, how Mayo is keeping patients safe. And this is a video that Dr. Amy Williams, current director of our practice, made to show all the steps Mayo Clinic is taking to ensure that when patients do need to come in person for their medical care, there are steps being taken to make sure that they remain safe. And with many of these steps, workplace exposure has dramatically plummeted. So let me shift over to show you that video.
Hi, I'm Dr. Amy Williams, and I've been at Mayo Clinic since 1990. I am a kidney specialist, a nephrologist, and I'm also executive dean of the Mayo Clinic practice. And together today, we're going to go in Mayo Clinic, and I'm going to take you on a tour to show you just how safe we are. Here we are at Mayo Clinic, and I want you to remember that your safety and the safety of our staff are the most important things for us, and we always keep that in mind. We are here to care for you, and we are ready. If I was a patient what would I do right now?
Then I would take your temperature with either the infrared thermometer or tympanic temperature.
Now, I understand that everybody, including visitors and patients, have to wear a mask.
Yes.
I'm going to just clean my hands here.
Absolutely.
This is so important to clean your hands. Between your fingers, backs of your hands, I even do it up my wrists. So doing this will kill that virus on our hands. Incredibly important. Look at this for social distancing. This is amazing how you have this set up. So people can only sit where there's no paper on the,
Correct.
no sign. So important.
They come in every half hour. They're cleaning every single chair, the side tables, the lamps, the reception desk, any door handles they can think of, the sanitizer bottles, the hand sanitizer bottles, the signature pads if the patient has to use those at reception. And then after each patient leaves, they're going and cleaning that chair as well.
All right, now we're going to go into an exam room. And I'm just going to turn the lights on. And as you can see, and as you know if you've been here before, that these rooms are always clean. And they're cleaned after every patient. We've always kept it clean, but now we're really concentrating on wiping down every single surface to make sure that you are safe and that our staff is safe. We know some of you can't get here for various reasons, but we still want to deliver your care and we still want to connect with you. But we can do that with video visits. And these video visits, I sit in front of the computer, I see you, you see me because of this camera. I have all of your information. It is just like you and I are here in the exam room. It is safe to see your doctor. It's safe to go to emergency rooms. So thank you all for coming on a tour with me. I hope that it is very obvious that our goal is to make Mayo Clinic as safe as possible for you and for our staff. The safety measures that are so visible today are in all of our sites in Arizona, in Florida, in the Midwest. We are here, we're ready for you, and we want to continue to care for you. So remember, we're safe and we're here to keep you safe.
And I wanted to share that video with you because one of the key messages is the safety component. What unfortunately has started to happen as the pandemic has worsened is that many are, due to sheltering in place or social distancing and fearing going in to see their healthcare provider, are avoiding seeking medical care. And we're seeing the number of patients with heart attacks and strokes presenting to emergency rooms decreasing. And this is happening all over the country. And I think that is leading to poor outcomes in those cases. So we want to make sure you know that most healthcare organizations, especially ours, are really going above and beyond to make sure that when you do seek medical care, that environment is as safe as possible for you to come in. If you're still apprehensive, I think exploring telehealth is certainly another option to keep in mind. We've been doing this now for many months, including using phone calls to do as much care as possible. The video visits have been tremendous, and as a physician, I'm just shocked as to how much information I can gather through a video visit, including part of the physical exam. You know, evaluating someone's tube site, someone's central catheter. A lot can be done through these video visits. So if you do have medical issues, please reach out to your local team and make sure you don't just ignore it because of the pandemic. You know, another issue that we also have been dealing with has been supply shortages. And with that, I want to turn things over to Lisa again to share with you how we have been dealing with these supply shortages.
So some examples of the supply shortages that we have seen, I'm going to review today, are probably things that you have dealt with as well. So starting mostly probably with the Joey and the e-pump bags, as well as the flush and feed bags that have been on back order. I know the companies are working really hard to provide patients at home what they need, as well as hospitals. But the reality is we just don't have enough. So one of the things that we did right away, probably about 6 months ago, is we changed many of our home patients and most of our patients that are immunocompromised, that we don't want them using a bag for more than one day. We changed them to the ZVEX pump, which is not experiencing pump bag shortages. So that was one thing we did. The other thing we did is it was a good opportunity to talk to our patients and say, do you really still need a pump at home? Maybe they were up to a high rate of 400 mils an hour, and we could actually transition them to gravity or syringe feeding. So it was a good idea, a good opportunity to look at our practice and decide if pumps were even still needed. Even in the hospital, and I know some hospitals across the country did have to go to gravity and syringe feeding because there just weren't enough pump bags. Like I mentioned, the flush and feed bags have also been a concern, and I think that's right now one of our biggest concerns. So some of the things that we have done is actually turn to the Oley supply exchange, and there are people on there that have flush and feed bags that they no longer need, which has really helped our patients who really need that flush and feed system. So if you're in that boat, that would be an avenue that I would really encourage you to look at the supply exchange for some supplies that you might need. When we weren't able to accomplish that, we did end up getting 2 feeding pumps at home for some of our patients, one that could run water and one that could run formula. But that is really similar to mixing water and formula together in the same feeding bag, which is a little bit easier, obviously, than having 2 pumps at home. So to get that extra hydration, we were mixing water with formula more often. Kind of switching gears about the supply shortages is kind of looking at your formula and deciding, if I couldn't get my Amazon Prime delivery, or if my supply company was not able to get formula to me, what would I eat? Just like I go to the store and I've stocked up on rice and pasta and frozen vegetables, what would you eat if you were not able to get out and get your formula? So having that backup plan, whether it be something that you can buy at the grocery store, something that you can make up yourself, but having an emergency plan just like the rest of the country does. In addition to having that backup plan, you don't want to run so low on supplies that you would not be able to eat if your supplies were a day or two late. Again, we don't normally recommend reusing bags, but it might be a situation where right now you try to reuse bags for a couple of days to save up some bags for your emergency supply, or have some extra syringes, or go online and purchase a few extra things to make sure that you have what you need at home if there was a delivery delay. So switching gears, we're going to talk about our third topic, which is something that we've been working a lot on, which is tube feeding formulas. How do I know which formula is best for me? And that's a question that we get a lot since there are so many formulas out there. So some of the things that we might look at when determining what is the best formula for someone, we look at their age. Can they tolerate a lot of fluid, or do they need a more fluid restricted formula? Do they have perfect GI function, or maybe do they have some malabsorption or dysmotility? Are there any food allergies? Are there diet preferences? Maybe foods that the family it has been eating, they want to eat something similar to that. But something to be aware of when you take into all these things into an account, many hospitals and home medical equipment companies do have a formulary that can kind of limit what formulas might be most readily available to you. So I was working on a project with Aspen, like Dr. Mundi mentioned, where we were looking at grouping formulas together and helping people choose which formulas might be best for them. With more than 100 formulas to choose from, we put them into 4 categories: adult, pediatric, infant, and then modulars like protein or carbohydrate or fat. The specialty formulas are kind of in their own categories, since many of those require extra medical justification, and that's addressed in the formula guide as well. So then within each age category, we broke the formulas down into kind of your standard formulas. Some of them have fiber, some of them don't, and they range from 1 calorie per milliliter to 2 calories per milliliter, so a little bit more concentrated. There's a category that has hydrolyzed or a little bit broken down formulas, elemental formulas that are very broken down for you, the commercial blenderized formulas, and then lastly, addressing homemade formulas. So Dr. Mundi is going to talk to you a little bit just more about choosing an enteral formula and the work that we've been doing on that.
Thanks, Lisa. And congratulations again on all the hard work that you've done with Aspen to be able to categorize these formulas and then also provide general recommendations. And we will have a link to those recommendations a bit later. However, I do want to shift focus because we do have a number of options available in terms of formula. Yet, despite having these options, we do continue to experience intolerance with formula in a significant number of our patients. And data for the home enteral nutrition population is much harder to find. However, there have been great studies looking at hospitalized individuals. This study looked at critically ill patients who were admitted and then given enteral nutrition and evaluated how many of them had intolerance. And you can see almost a third, 30%, had intolerance to that enteral feeding in terms of having residual gastric residual volume, abdominal distension, vomiting, diarrhea, or discomfort. When looking at hospitalized patients, again, studies evaluating this both in critically ill and non-critically ill patients have continued to show pretty high rates. And again, it changes in terms of the symptoms that patients typically report, but regardless, we do continue to have intolerance. And anecdotally in our practice, we're also seeing the same thing. We're seeing that rates of intolerance can be high. And with this, what are our sort of next steps that we should take part to help patients tolerate their formula better? One of those options, amongst other options such as switching to whole food, blenderized tube feeding, one of those options has also been peptide-based formulas. And so we wanted to look at this a little bit more closely in our own patients and carried out a study. And we found that between 2016 and May 1st of 2018, we really had 95 patients who were given peptide-based formulas. Out of those, 53 of those patients were started directly. So the first enteral formula they received was a peptide-based formula. 42 of the patients were switched from another formula. And when we look at this closely, you started to see some of the patterns of why. You had one group versus the other. So looking at the primary diagnosis, why did that individual, need enteral nutrition? When we looked at the group that was started on peptide-based diet in the beginning, and this is, again, formula that is partially broken down, you could see there was a big component there of malabsorption. Whereas those that were switched, tended to fit more of our pattern of home enteral nutrition that we often see. Still, pancreatic adenocarcinoma and some of the GI carcinoma being a little bit higher than typical enteral population. So here are the indications for that peptide-based diet. You can again see fat malabsorption, pancreatic insufficiency being some of the top ones in those individuals started on peptide-based diet. In terms of those switched, again, this was mainly fitting with our kind of current or past intolerance to their previous formula. So here are the formulas that we found in our study, looking at which ones were used by our group. And you can see a number of them that are the Peptamen, the Vital, Kate Farms as well. And then comparing continuous versus intermittent gravity feeds. But really at the heart of this was our analysis in terms of those who switched to peptide-based diet, because that allowed us to look at, well, what happens when you make this transition? We were able to compare the data before the switch to data after the switch. And you can see here their symptoms dramatically improve, right? Almost nausea and vomiting is cut in half, diarrhea cut in half, abdominal pain, cramp, same thing. In fact, individuals reporting no symptoms improved from 20% up to 49%. So pretty incredible results. And I think what was really striking for us was to also look at resource utilization in this component, because that's something that had led to a great deal of reluctance on our part to transition patients to a peptide-based diet, because it is more expensive. However, we found that with this transition, the average number of patient phone calls decreased dramatically. The number of ER visits pertaining to enteral nutrition decreased significantly. The average number of scheduled provider visits decreased significantly. So when you start to look at those costs, and I think we need to do a lot more work in this regard, but when you start to look at those costs, I went online and kind of looked for literature review to see what other studies had reported some of these costs, and these are just some examples where this group noted that the average cost of an emergency room visit for constipation was $2,300 in 2011. This group noted that the average cost of managing diarrhea, especially if a person is hospitalized, range from $3,600 to $5,000. So you can see how these can add up when a patient is intolerant and coming to the ER and undergoing a CT scan or other imaging. That cost comparison can add up quite a bit, perhaps making it way more economical to consider transitioning that individual faster or sooner to a peptide-based diet. It wasn't just our data. We also found, and this is a abstract that was submitted at one of the international nutrition conferences. They also found very similar results. They had a much higher number of individuals, but the results were very similar. You can see dramatic reduction in terms of nausea, diarrhea, constipation, and again, number of patients that are affected by multiple events as well can improve significantly with this transition. So with that, we continue to do more work. Again, our focus, singular focus, is to make the lives of our patients, our consumers, better, and we continue to look for opportunities to do more research. Here are some of the guidelines that Lisa and others in Aspen have really been working on to guide regarding adult formulas. one other sort of plug, if I could, at the end, is to really put in a mention about our home enteral nutrition service. So as I was mentioning before, our singular goal is to really improve the lives of those who need enteral or parenteral nutrition at home. And unfortunately, in order to do that, we need a lot more data. We need to understand how enteral and parenteral nutrition are being provided in the home setting. And the best way to do this is really to ask you, the consumers. And so we are working on conducting another survey. This has taken us more than a year to develop, especially with the COVID pandemic, but we are ready to launch this survey. And I'll work with the Oley team to see if we can place it on their website. Feel free to contact us as well if you're interested in participating. But our plan is to, focus on the consumers, the caregivers, and then also the providers. And we'll be doing this with many of the national organizations, but any help you can give us to get this in front of as many people as we can, to gather information about how enteral nutrition is being provided. What are the issues in terms of ENFit? What are the issues that you're having in general with your enteral nutrition? And also, what are the issues that coronavirus or COVID-19 is presenting? So with that, I will end and turn it right back over to Lisa and our home enteral nutrition team.
Thanks so much for joining us, everyone. We really look forward to seeing you face to face at Oley 2021.